May I now request our next speaker to come over? I would request Dr. Manoj Pandya to come over, and he would be talking on role of inositols in adolescent PCOS.
So friends, my today's presentation will be role of inositols in adolescent PCOS. The three components of presentations are adolescent PCOS, and role of adolescent inositol in adolescent PCOS. The group of young girls between 10 to 19 years of age who are no longer children but who have not yet become adults, they are often thought to be adolescent. PCOS, many a time, it is not properly evaluated or not diagnosed in this group. Many serious disorders in adulthood have their roots in adolescence, like diabetes mellitus has its root in fetal life, growing into adolescent PCOS, leading to infertility, gestational diabetes mellitus, and culminating into metabolic syndrome and full-fledged diabetes mellitus. As characteristic of normal physiological changes occurring during the puberty, they overlap with signs symptoms of PCOS. Adolescent girls pose a particular diagnostic problem, which my previous speaker had highlighted. Understanding the role of insulin resistance as a pathological contributor to influencing HPO axis. Pituitary LH is necessary to sustain ovarian androgen, but it is not sufficient to cause excess of the ovarian androgen. Insulin-resistant hyperinsulinism, it acts on theca cells to aggravate hyperandrogenemia, which in turn provoke the LH excess. LH excess again act on theca and luteinized granulosa cells to worsen the hyperandrogenism. So there is an interplay between the hyperandrogenism and LH excess. This LH stimulates luteinized granulosa cells to secrete estradiol also, which suppresses FSH secretion. Hyperandrogenemia resulting from dysregulation of this enzyme, it is a risk factor for metabolic syndrome independent of obesity and insulin resistance developing from serine phosphorylation, excessive serine phosphorylation. As there is higher prevalence of metabolic syndrome in adolescents with PCOS, early diagnosis will definitely help in preventing long-term complications, and particularly those adolescent girls whose triglyceride to HDL ratio is more than 3.2, we should target them for proper evaluation. Yesterday, Dr. Uday Thanawala has nicely carried out the stress which poses on the PCOS patient. So even if there is a wrong diagnosis, it will create a tremendous amount of stress among this class of the patient. Up till now, there has not been any conceptual definition on adolescent PCOS established. So none of the group, maybe NIH, Rotterdam, or AEPCOS, has proposed the different criteria for diagnosis of adolescent PCOS. It was the Sultan and Paris who came out with at least, if there are 4 out of 5 criteria present, then we can say that it's a adolescent PCOS. And we all know that transabdominal ultrasonography, it has got its own technical limitations in diagnosis of PCOS in adolescent girls. Though follicle access, it is the best criteria, but threshold is again technology dependent. And with the newer machine and 8 megahertz transducer, 25 follicle per ovary, it is a diagnostic criteria considered to be a PCO appearance. Apart from Sultan and Paris, it is the Carmina and colleague considers all 3 Rotterdam criteria to be present for the diagnosis of adolescent PCOS. The clinical expression which we can have in adolescent PCOS may be postmenarchal, premenarchal, familial. PCOS in adolescent previously diagnosed with central precocious puberty or IUGR, and insulin resistance and hyperinsulinemia in early puberty. Our aim of treatment would be to improve the self-esteem of young girls who matures into womanhood, normalize the menstrual cycle, decrease or eliminate the hirsutism and acne, treat glucose and lipid abnormality, and achieve the ovulation. And for this successful outcome of our aim, we have different modalities to treat adolescent PCOS with specific therapeutic target. To overcome the drawback associated with all the other modalities like OC pills, anti-androgens, metformin, insulin sensitizers like inositols, they have gained special interest in the management of insulin resistance and PCOS. Friends, why inositol as insulin sensitizer? Because in PCOS with insulin resistance, there is impaired suppression of hepatic gluconeogenesis, leading to abnormal insulin receptor signaling, which in turn affects the insulin-mediated glucose transport into muscle and leads to hyperglycemia. This resultant hyperglycemia stimulates the theta cells, beta cells in the pancreas and ending up with the compensatory hyperinsulinemia. So friends, if you look at the chemical structure of the inositol, it was in the 2013 International Consensus Conference where the clinical role of MI and DCI in the management of metabolic syndrome and PCOS was identified. If you look at the chemical structure, they are the hexa-hydroxycyclohexane with different 9 stereoisomers. Out of that, MI and DCI has created a special interest, or they have been given to good importance. And they belong to B complex family, particularly B7, as they are water soluble, devoid of any major side effect, and they are quite well tolerated. The biological role inositol play in the cell, in the cell membrane, they are as phosphatidyl myoinositol. They are the precursor of phosphoinositides. They are involved in signal transduction pathway. They act as a secondary messenger for regulating insulin, TSH, and FSH, and they enhance the intracellular calcium oscillation, which is positively related to meiotic progression of germinal vesicles. Friends, as insulin resistance has pivotal role to play in PCOS, if we look at the insulin action with specific relevance to MI and DCI, insulin regulates blood glucose via cellular glucose uptake and glycogen synthesis. At peripheral tissue, myoinositol promotes the glucose uptake, while DCI promotes the glycogen synthesis. Myoinositol, by involving into insulin signal transduction pathway, promote the cellular glucose uptake. It regulates the FSH signaling. It promotes the follicular growth and maturation. It helps in fertilization, embryo development, and meiotic progression of germinal vesicles. It is enhanced. While DCI, being secondary crucial messenger in same pathway, it induces the glycogen synthesis, lowers the testosterone or androgen level, and decreases the risk of metabolic syndrome. Understanding the insulin signal transduction pathway, when insulin reaches the cell wall binding to receptor site, it forms the insulin receptor substrate, which in turn, in presence of adequate myoinositol, should activate the PI3 kinase. But with MI deficiency in PCOS patient, this inactivated PI3 kinase decreases the translocation of GLUT4 to the cell surface and resulting into decreased glucose uptake. If you supplement these people with adequate myoinositol, it will activate the PI3 kinase, resulting in increased GLUT4 translocation to the cell surface and increased glucose uptake. Myoinositol does not only helps in activation, but it helps in production of PI3 kinase too. While metformin, it is said that it only activates the PI3 kinase. Now, based on this theoretical knowledge, there are umpteen number of clinical studies. Today only in the morning, when we were discussing about the role of inositol, I think I came to know there are 39,000 papers till 2017 on myoinositols. So, supporting the practical use of myoinositol and DCI in PCOS. In a clinical study of Benelli et al., presented in International Journal of Endocrinology in 2016, 46 PCO patients were divided in 2 groups. Group A were treated with combined therapy MI-DCI in the ratio of 550 to 13.8 milligram, and Group B were treated with 200 microgram of folic acid. 21 young overweight PCOS women treated with combination MI-DCI, they showed effective improvement in LH, free testosterone, insulin, and HOMA-IR compared to placebo group treated with folic acid only. Even SHBG level, it increased in the patients who were treated with the MI-DCI combinedly. In another RCT of 50 patients conducted by Nordio et al. To justify the effectiveness of combined MI-DCI treatment, 24 were treated with MI monotherapy and 26 patients were given combined MI-DCI for 3 to 6 months. Here also combined MI-DCI treatment showed significant improvement in fasting insulin, glucose, HOMA-IR after 3 to 6 months of therapy. Even after 3 months of MI and DCI in these patients, hormonal parameter like testosterone, it decreased to 50 nanogram from the baseline of 95.4. Free testosterone came down to was 4 nanogram from baseline level 0.85, and SHBG increased to 180 millimole from baseline 145. Supporting the further role of MI-DCI in adolescent PCOS, because we are looking at the adolescent PCOS management. In clinical study of Lali, Khalades, Ludmila, and Nana, 60 adolescent girls with PCOS were divided in 3 groups, 20 each. Group 1 was given drospirenone with ethinyl estradiol in standard combination which is available in the market. Second group was given 4 gram of minoxidil with 400 microgram folic acid. And third group, they received both OC pills plus minoxidil 400 microgram. Here, combined MI plus OCP in adolescent PCOS, anti-androgenic effect were enhanced, so it was a beneficial effect. Negative impact of OCP on weight gain was balanced, and metabolic profile improved with all the parameters. So MI can prevent developing serious metabolic disturbances in adolescent with PCOS in future. Up till now, we are talking about the ratio, which is 40:1 available with the in-market tablets. But every tissue has its own specific MI-DCI ratio, which translates into different tissue function. And each tissue has got typical conversion rate too. And friends, you all know that minoxidil molecule as such is a matter of great debate. So its ratio has also ought to be a matter of great debate. In diabetes mellitus, minoxidil is excreted in urine due to competition of glucose with minoxidil for tubular transport. In healthy ovary, MI-DCI is said to be 100:1, which goes down to 0.2:1 in PCOS, that is the follicular fluid level. So with such great imbalance in MI-DCI ratio in PCOS ovary, inositol plasma levels are quite different. So we should focus more on dosage rather than ratio. And ideal therapeutic dose of DCI is being, the suggested is 300 to 600 milligram, and minoxidil is 1 to 4 gram per day when given in combination. And particularly in adolescent PCOS, when androgen profile is to be treated, the duration of treatment should be for 6 months. To justify the importance of optimal dose, that is 150 milligram, not 13.8 milligram, if we look at the study, article of Belargan et al. And Henmark et al. Presented in Endocrine Journal of 2014, comparing MI-DCI deficiency, there is more prevalent DCI deficiency at the periphery, which is 47%, as compared to MI deficiency in ovary, which is 28%. And as per the Belargan J et al. Study presented in Diabetic Care 2006, PCOS patients have lower plasma concentration of DCI, and there is 5-fold greater urinary clearance of DCI as compared to normal women. While urinary clearance of minoxidil did not differ between PCOS and normal women, induction of defect in renal clearance of DCI further amplifies the insulin resistance. So highlighting the importance of optimal dose of DCI, that is 300 to 600 milligrams, the study of Nestor et al. And Gananji showed the favorable effect in hyperandrogenemia. There was 73% reduction in testosterone, 83% improvement in insulin sensitivity index, and 35% reduction in LH-FSH ratio. Reflecting in another study presented in Endocrinology Practical of 2002 about the effect of DCI in lean PCOS, 20 lean women were treated with 600 milligram DCI OD for 6 months, 6 to 8 weeks. With this optimal dose, DCI reduced circulating insulin, androgen level, and help to improve the metabolic features too. Now question arises, are there any enough study, or because all the time we have seen that minoxidil has not got enough study to support this use. So are there any study comparing the low, that is 13.8 versus optimal 150 milligram of DCI dose? And here is the interim result of ongoing clinical study of Dr. Nicolas Mendonza from Granada in Spain, where 56 females from 8 centers of 6 different regions of Spain were recruited. 29 females have completed the study, with half of them with 550, 150, and remaining with the 13.8 milligram. The group 1, which was treated with DCI 150 milligram with MI, they showed 25% reduction in insulin level, 28% reduction in insulin resistance. The group 2, which was given 13.8 milligram, there was no significant difference in the level of glucose and HOMA-IR. If you look at the graph, the insulin level, only 2 or 3 slides. Insulin level and HOMA-IR, it improved with group 1 given 150 milligram of DCI, and no doubt your pregnancy or mature oocyte is not important in adolescent PCOS, but still 85% showed the improvement. Higher pregnancy rate was observed with the high dose DCI, that was 3 times higher. So in summary, the clinical pulse are deficiency of DCI in metabolic organs leads to insulin resistance. Deficiency of MI in ovary leads to poor oocyte quality. When MIDCI therapy given in combination, it improves metabolic, menstrual, ovulatory, and hyperandrogenic features of the PCOS. And the optimal therapeutic dose of DCI is 300 to 600 milligram, myo-inositol being 1 to 4 gram, but the duration for particularly androgen profile has to be for 6 months. Thank you for patient hearing.